Welcome back, fellow scientists. This is Mr. Leo,
This is Leo.
and I figured that before we left our chapter on blood, we needed to bring in the expert to talk a little bit about administering medications through blood and then also drawing blood for diagnostic tests. So why don't you tell them a little bit about educational background and then work history and why you like being a nurse?
Okay, I've been a nurse since 2008, 2008, 2009, somewhere in there. It's I went to Whitworth for 2 years for the nursing prereqs, and then the 2 years at WSU at their nursing school, and
Go Cougs.
and then got a job as a community health nurse. I worked at the Spokane Regional Health District for 3.5 years, and worked with patients with tuberculosis, worked with patients with HIV, did a lot of testing for that and education. I also did a lot of vaccinations. Yeah,
She used to shoot people for a living.
Yes, yes.
Yeah, give them shots.
So childhood vaccinations, travel vaccinations.
You worked with a lot of refugees.
I did. I did refugee screenings. Part of that job, it was kind of like social work as well. Refugees coming into the country would see me first. I would be their first healthcare provider, and then I would connect them with doctors in the community, specialists, whatever my assessment deemed that they would possibly need. And that was wonderful. You got to know the families and got to develop relationships with the kids. It
Yeah.
was amazing.
And that was a full-time, regular 9 to 5, Monday through Friday
Yeah, that was great.
type
It
nursing
was really
job.
great.
Yep.
Then we had our first baby, and I wanted to be home with kids, and so quit my job and came home as a mom for a year. No work, and then a lot of work as a mom. But then I got a job at the Spokane VA Medical Center, and I worked there for 6 years. I worked there per diem, so that meant I got to choose my hours. They would say, "Hey, can you work this?" I'd say yes or no. It was wonderful. So I'd work 12-hour shifts on their cardiac floor, and so worked with rhythm strips, patients with heart attacks. They'd come to the ER. Then after they got stabilized, sent up to us. Um,
So all those rhythm strips that we looked at, we just looked at like three of them, like regular and VTAC and AFib. But there are many, many more. All those rhythm strips, like she has to know,
yeah,
or she had to know, to work on that floor, and she would get tested. What is it? Every year? Every 2 years?
it depended what management was doing at the time, but
But yeah,
every
so
6 months maybe.
that's something to look forward to if you
Yeah.
if you want to become a CSU, a cardiac intensive care unit nurse. So that's pretty cool.
Yeah. And so then after that job, I more recently started doing home infusion. So I've become a home infusion nurse. And so now I take care of patients outside of the hospital. Um, Patients will come home with a need for IV antibiotics. Maybe they've been in the hospital, they're real sick, and finally they're stabilized. They don't need the hourly nursing care anymore. And they come home, but they still need daily IV antibiotics. And so a patient can't start their own IV. Um, they can't take care of their IV after it's placed. You see on your screen here, this is just um, the peripherally inserted IV. Just this one's in the person's hand here. We can have that up on the inside of their elbow. You see when the IV is placed, there's a needle first, and then this white tube, that's the catheter. That's a flexible straw that goes around the needle. Once a needle gets in the right place, then you push this piece, the green piece, you push it down in there, and the catheter goes in, and you pull the needle out, so you don't have a.
Okay, Department of True Confessions. When I've had IVs in the past, I'm scared of needles. I don't like needles, and so I don't look at them. And I always thought that the needle stayed in my arm, and so I was afraid to bend my arm. I was like, oh, I got to keep it really straight because I got this really sharp piece of metal like in my elbow, and if I bend it, it's gonna slice through everything, and it's gonna really really hurt. But now I'm learning that no, it's just a thin flexible tube, and I don't want to bend it because then that'll pinch the tube, right? But if I do accidentally bend, it's not going to like slice through muscle and
No, you're
tendon
not
and
going.
bone and everything like that. So FYI,
Yes, for
FYI.
anyone else who may have that same fear.
So IV venous access is a really good way to administer medication. So this is kind of the classic way to
Hmm.
administer medications. And then do you want to go into the pick?
Yeah, we can go on the pick line.
Okay, so this is classic, but then this, if you're really getting some good stuff.
If you need long term, or
Okay,
you
long
need
term.
a caustic medication.
Yeah.
So caustic, it's going to be hard on your veins. Um, so a PICC line. So this is still peripherally inserted. You see, so insertion site is here, and on this person, on the actual human arm, insertion site is actually right here in the middle of this white disc. It's called a biopatch, antimicrobial disc. So insertion site is there, but the tube in an adult, it's about 40 centimeters, and it goes all the way down in the right atrium of the heart. And so you have a harsh medication, it's not going to eat up your veins. It's going through that tube, goes to the heart where it's filtered out with the blood because of high blood flow, of course.
Diluted in the blood.
Hmm.
Yeah.
Yeah. And so a patient with a PICC line, we'll get them, we'll have a patient who just had a PICC line put in and then they go home. And we'll go for our first visit and they'll say, hey, I feel like I'm having a heart attack. I feel anxious. I'm feeling heart palpitations. Something feels wrong. And often what happens is the placement is just a little bit off. It's too deep. So we'll remove this dressing here. There's like this sticky, it's called Tegaderm, the sticky saran wrap material over the PICC site. So we'll remove that dressing very carefully, mind you. It's not easy. Everything is super sticky. And then you're trying to pull the dressing off without pulling the PICC line out. It's very difficult. So we pull the dressing off and we'll pull the PICC out a little bit, maybe half a centimeter, maybe a centimeter. And then suddenly the patient's symptoms go away. It's incredible. They'll say, wow, I'm fine again. I feel perfect. Um, so that's something that we do. I'll receive patients who were in the hospital, and I was talking about this before. They go home and they need IV antibiotics for maybe 6 weeks, 12 weeks. And so, what I do, I go to their home and I teach them how to administer their IV antibiotics, or I'll teach a family member how to access their venous access device, as we call it.
So that they don't need a nurse to come over every single day.
Yes,
Yeah.
because that's very
Yeah.
expensive.
Yeah.
Some
But you do go
we
and see
do. We do have a few.
every day.
I have a couple patients right now who have no community support, no family support, and that one gal, her eyesight is very poor. She's also very nervous. We don't trust her with her PICC line, so we go see her every day, and she is doing amazing. She would be dead if we weren't seeing her. It's,
But then also besides, so not just administering the medication, even if they administer the medication themselves, then you still have to go and you still have to change the dressing.
yes.
So talk about risk of infection.
Okay, so let's go back to this other slide. This is just that little peripherally inserted. It's just, you've got this little tube in here. These IVs last for, if we're lucky, will last 7 days, but usually they last 3 days on average. And then the site gets mad. This all gets inflamed, everything in here. And so then we remove it. We start a new one if the patient needs it. And infection here, it's okay. It'll heal. It's fine. Now this one, imagine you get an infection here. So pretend this dressing peels up, gets wet, water from the shower. The patient was showering, they didn't cover their PICC line site well enough. So they got dirty shower water down into their PICC dressing right at that PICC site. Now now that we've got, or even worse, the patient didn't clean their needleless hub, their needleless adapter here before they administered their medication. Now we have Staph aureus everywhere. We have all sorts of nasty microbes everywhere. The patient's skin there, it's been resting on their skin. They forget to clean that, and then they put their medication in through there. They just brought all sorts of bacteria up, and that's going to go, oops, I didn't mean to move that. That's going to go all the way up their line, all the way up straight to the heart. So we can have patients go septic quick. It's very scary. So that requires an RN to do a dressing change at least weekly, if not more frequently, depending on the patient and their needs and things that have happened. And then we're also troubleshooting. Clots will form. A clot will form all the way at the end of the PICC line. And so then you can't draw blood from it. sometimes you can't even push fluids through, and so we have to come and administer anti-clotting agent to
Activase.
Activase is
Yeah.
what it's called. Yep,
ACE, right, is a is
there you
a
go.
is an enzyme suffix. All right. So then, last thing about the PICC line, what types of, you already talked about antibiotics.
Hmm.
What other types of medicine would you administer through a PICC?
Well, right now I have a little boy that I see. He that he has hemophilia, and so for him, he needs his clotting factor every day. And so, do you think a little 7-year-old boy would like to get a needle stick every day?
Mm.
I mean, it is hard to just draw blood from a yeah little boy. So to have to poke him every day and give him his medication, no, not going to happen. Or it's traumatic. We want him to get to be a little boy every day. So I do his dressing change once a week. And normally, PICC lines, they don't last very long. They'll last
They'll get
a couple
infected.
couple months
They'll
because
clot
of
up.
infections, clotting, all sorts of things. But when they're cared for, it's incredible that we've been able to maintain this little boy's line for over 2 years. And it's we've worked with his super sensitive skin because most people, the adhesive bugs them, all the different things that we're using to secure the line, it will make the skin become inflamed, rash out, it'll break and be open and bloody. It's awful. And so we work really hard to um, adjust our dressing products with the changes in the patient's skin because the skin will evolve throughout the course of treatment as well. What a product that used to work 3 months ago on a patient suddenly doesn't work, and now we have to figure out something new. And
Yeah.
that's something that makes the job fun. It kind of becomes an art. Every patient's dressing is different. Um,
Yeah.
some of them are very challenging.
All right, then really quickly, this is going to be a long video, but that's okay. We like geeking out on this stuff, so forgive us. It's like you're at our dinner table,
Yeah,
and it's just normal
but we
conversation.
don't talk about this at the dinner table, really.
No, it's usually it's Legos and different things like
Yeah,
that.
because the boys.
Yeah, yeah. But anyway, so we got antibiotics and we got clotting factors. We got
Mm-hmm.
hemophilia. You also administer iron for people who are anemic.
Uh-huh. We do.
And then one of your main clients are pregnant mamas
Yeah.
that can't stop vomiting,
Yes.
and so they vomit so much.
Okay, so we've got these mamas, they have something called hyperemesis gravidarum. And so hyperemesis, too much vomit. And the gravidarum just refers to the fact that they're pregnant. And so I've had mamas that would vomit 20 times a day. So they're not drinking fluids, they're not eating food.
Well, they might be drinking fluids, but they're
But
not
it's
keeping
not,
them and
yeah.
absorbing them and using
But
them.
I mean, the thought of water makes these women just so nauseous. And it's amazing. They will say, I've not eaten in days, drunk in days, and yet I'm still vomiting. Where is the fluid? Where is it coming from? It's incredible what these women suffer through. And so these women often end up with a PICC line. And so then we're helping them, we're teaching them how to administer hydration. So they'll have huge bags of fluids and a pump attached to them that they have to carry in a backpack all day long. And sometimes they can't, if they can't get any food down as well. Then they're also carrying an extra separate bag full of TPN, which is a total parenteral nutrition. So that's nutrition through the IV line. And so they're carrying a 20-pound bag and it gets lighter throughout the day.
So they're drinking through their PICC line, they're eating through their
Yes.
PICC line,
And
and
they're receiving their antiemetics, so anti-vomiting, anti-nausea medications as well through their lines. Also, the acid reflux, so an acid reducer as well, because so many of these mamas have heartburn. And so we teach them how to use the medication, and we visit them and care for them as much as they need to help them. I mean,
yep,
it's
yep. All right, perfect. So we talked about administering drugs through veins, and then we also mentioned at the very beginning about how it's a good diagnostic tool to remove blood from the body and then to analyze it. So we're going to shift gears just really quickly here. I apologize, we are not professionals at all. But really quickly, I want to talk about three kind of classic tubes that you may or may not have seen at your doctor's office. And if you go into the medical field, you will definitely have to learn about these. I learned about these just in my regular biology classes at Whitworth, and I'm not in the medical field. Although I have threatened that if this whole teaching thing doesn't work out, I'm going to go back to school and I'm going to become a nurse because it looks fun and amazing and awesome. And yeah, I don't know. I just love the human body because it's intricate and amazing, and God is awesome. Anyways, I digress. Getting back to the tubes. We have a yellow top tube and a red top tube. Both of these, when you put blood into them, the blood will clot because that's just what blood normally does when it's disturbed and when it's exposed to oxygen. So the red top tube, there's nothing really in it. There's no anticoagulants or anything like that. So you'll get a clot. Oops, sorry, I'm blocking. I don't know where to hold this. So you'll get a clot that kind of forms right down here at the bottom, and that of course holds your red blood cells and your white blood cells and your platelets and your clotting factors, right? And then you'll get up here at the top, you'll get the plasma, but it's not called plasma anymore because plasma is if there are clotting factors in the liquid. All the clotting factors are down here in the clot, so now it's called serum, right? So you'll get serum up top and you'll get a clot down below in the red tube. In the yellow tube is a little bit better. You can maybe see there's like a kind of a waxy plug. Okay, it's a gel. Um, little thing down there. So what they'll do is they'll put whole blood in, right, and then they'll take to the lab and they'll spin it down in a centrifuge. So that separates things by density, and all the formed elements and the clotting factors will make a clot beneath this gel, and then the serum. So the plasma
So the gel will
without.
rise.
Yep, the gel's going to be kind of up here once they spin it down because the blood is more dense, and so it'll go down there. So once they spin it down, then the blood will be down here, and then the gel will be in the middle, and then the serum, which is the plasma minus the clotting factors, will be up here. And so they would use these two tubes to analyze anything that you want to find in the serum, anything like hormones or nutrients or salts or gases, right, or anything like that. Now this is a purple topped tube, and this has I don't know if you guys can see it, but it has a thin film on the side, and so this has an anticoagulant in it, and so whole blood goes in here, and it's not going to clot. It's not going to form that clot in the bottom. So it's just gonna maintain being liquid blood, and it's going to stay that way until lab tech needs to analyze it or get rid of it as medical waste or whatnot. But this would be used if someone wants to analyze number of white blood cells, red blood cells, platelet count, different clotting factors, maybe analyze the clotting factors, different things like that. So red and purple, right? They are going to let the blood clot, or sorry, red and yellow, they are going to let the blood clot. And then purple anticoagulant is not going to let the blood clot. All right, now my least favorite part of the video, her probably favorite part of the video. She's going to demonstrate how to not really start an IV, but the process is kind of similar. She's going to demonstrate how to draw blood, and she's going to talk through kind of what you're looking for with veins and what veins to choose and different things like that. Because I know some of you are looking towards going into nursing school or going into the medical field. So this is kind of your very first little foray into the whole world of being a nurse or a phlebotomist or accessing veins. So she's going to do that, and she's going to kind of talk through what she's doing.
Okay, so I will try to make sure I'm not in front of anything. It's hard to make sure the camera can see what I'm seeing. So we'll try to make sure we get rid of shadows. Okay, so my hands are washed. I'm not wearing gloves. One thing, we live in the same house, so we're both used to the same microbes. Another thing is my gloves aren't going to protect me from a needle stick. If I poke myself in the hand and I'm wearing gloves, I'm still going to be getting contaminated. So it depends on the facilities.
And you can feel veins better.
You can. It's
Without
really
gloves.
nice. Yeah. Okay. So this is textbook. This is great. We get to see here all these veins. Mr. Leo's veins kind of rest on the top. I have patients where you have to dig deep for veins, and that's not very fun for anybody. I mean, it's fun when you get it, I guess, but it doesn't feel good to the patient. So you have to go deep. It's a fun challenge, but Mr. Leo's veins are easy. You can see them. The rest, this one is anchored. This is his antecubital. You got cephalic and basilic. And so that's usually, antecubital is where phlebotomists usually go. I'm sure most of you have had your blood drawn at some point. And so they usually go there. It's easy. It doesn't usually move on you. down here you see, look, that one looks like it would be a great idea to go for it, but
That one looks easy.
it looks so easy, but all I have to do is barely press on it and it moves. It almost moves before I get to it. It runs away from me. If I put a needle in there, unless I hit it fast and it's gonna just
Dead on.
it's just gonna move. So we don't go for those. We like them to be anchored. No, it's just that one was so surface. And now it's also fun to see the bifurcations. You get to see this road map on his arm. You see how it's raised right there. There's a valve right there. And
So
there's
remember we talked about how arteries don't have valves, but veins do? Well, anywhere you see a little bump, that is a valve.
and then
in a-
also at the bifurcations.
Yep, in a vein. And so as a nurse, as a phlebotomist, you want to avoid those because you don't want to put your needle through a valve.
Yeah, sometimes you won't get blood return. If I put a IV through a valve, it's that IV is not gonna usually work out too well for us.
All right, so
No.
let's get this over with.
Okay, sorry. Yeah, we've left that tourniquet on you a while. Sorry. Your whole arm's gonna go numb. Going to the ER. Okay. Okay. Can you? Oh, we can see. I think we need to turn that way. There we go. Okay. So we're cleaning my fingers there. Cleaning with alcohol. I've got a 21 gauge needle here. That'll let the blood go through pretty quick. It's not huge, but it's a little bigger than. So, okay, so make sure we can see this. I feel like I'm getting. Okay, so we go at an angle. I'm holding his vein steady here with my finger. I'm pulling back. I'm gonna go in quick. I look for the flash. Oop. Sorry. Okay. Can you see here? Doing okay?
Yep.
Okay.
This is just another reason to not like needles for me.
Yeah, I'm sorry. It probably hurts. Open your hand. He's squeezing his
Oh,
hand and
sorry,
hurting
okay.
himself more.
Oh, there you go.
You don't need to.
I was just tense.
Yeah, you were very tense. Okay, so we've got plenty. So do you want to pull your tourniquet there? I'm going to get this cotton ball here because we're making a mess here. Okay, you push pressure or else you're going to bruise.
Yep.
I went in there twice, so okay. So now we're going to clean the blood off there. So we've got blood everywhere. And so then what we do, clean it off your arm too. You just keep holding pressure.
Yep.
I've got a blood transfer device here. So I remove, I have this on real tight, my syringe from my tube. Then I attach it to my blood transfer device. Then I take these 3 tubes that we showed you before, and this is really cool. So these are all vacuum sealed. So I don't have to push on the plunger here. I don't have to push on the plunger here. It's just gonna go automatically. I'm just gonna let about 2 mils go into each tube. For this, the lab likes 3 mils, but I'm not sending this to the lab. We're just showing you guys. So we're just gonna do a little bit in each. We always shake them so that the film in there, the gel in there can be coated with all that blood.
There is any anticoagulant.
If there is.
Yep.
Yep.
Then it gets mixed all throughout.
Yep. And each tube is different.
Yep.
Okay, so right now, since we don't have a centrifuge to show you, this guy, after it's centrifuged, remember, you're going to have this clear yellowish serum at the top, and then the gel here will be in the center, and then you'll have the solids, your formed elements down below.
Yep.
So that one, let's see, these two were the ones without the anticoagulant.
Without the anticoagulant,
yep. Your lavender, your purple one has your anticoagulant.
There you go. All right, so your assignment is to research, and this is kind of due like at the end of spring break, so it doesn't have to be anytime soon. But your assignment is to research one diagnostic blood test, and I'm looking for a couple things. I'm looking for the name of the test. I'm looking for what molecule or cell the test is after, and in that I'm looking for like an approximate range. right, of molecules and cells. So this is normal. If it's too high, it's this. If it's too low, it's this. I'm also looking for the condition that they're trying to diagnose. And then if you can find it, tell me what type of tube they would be using. Are they going for whole blood? Are they going for one of the types of cells, or are they just going for something that's in the serum or the plasma or whatnot? And then of course you need to cite your source. So that'll be on LMS RunWeb, and you can do that whenever you have time today or sometime during spring break. So this has been Mr. Leo.
And this is Leo.
Hopefully this has been fun and informative, and I will see you on the flip side.